Okay, and I just want to see if our co-moderator has joined us. Pooja, are you with us? If you can maybe just unmute yourself and say hi. Well, she may not have made it. If not, I'll ask, if Pooja doesn't make it, maybe Theo, I'm going to ask you if you can co-moderate. Okay?
Okay, yeah, sure, Dr. Nadeem.
Thank you. So, Sunil, I think we should start so we don't get late. Let me just start the recording here. Okay. So good morning, everybody. Thank you for joining us again in our cath conference. And I want to really thank good friend Suni Rao from Duke. Sunil, it's really a pleasure to have you here and talk to us about tips and tricks for radial. I feel kind of crazy as a European asking an American to do this. But I really also admire the way at Duke you've pushed the radial first way of doing PCI and intervention and how you've turned things around from femoral to radial. So I think the fellows will really enjoy learning from you. I'm a strong believer in radial first, and we're all looking forward to learning from you. Thank you so much for joining us.
Great, and thanks so much for having me, Azim. This is fantastic, and I really appreciate the invitation. You know, when we first started studying radial access in the US in 2008, it was about 1% of all the PCIs done in the US. The latest data, although it's a little bit hard to find, suggests that we're now over the 50% mark. So things have changed, and I think we have actually the fellows to thank for that who are going into practice adopting a radial first approach. So I'm going to talk about tips and tricks for radials. I have no consulting relationship with industry since March 2018. I want to thank some of my colleagues around the country, or Dear Shroff, Samir Pancholi, and Gilchrist for slides. So I think, this is a talk that's titled Tips and Tricks for Radial. It's aimed at fellows in training who are going through the cath lab or those who are in the interventional lab. So, let me talk a little bit about what I'm not going to talk about. So what I'm not going to talk about is a lot of the data, because I think that we could spend the entire hour going through the nuances of the different randomized trials, talking about, how these trials were designed and what other strategies they studied. The reality is, if you pool all the data together, and this is a little bit of an outdated meta-analysis, but still a very, very good one by Giuseppe Ando, you can see that in the acute coronary syndrome trials comparing radial versus femoral, the pooled effective radial approach is to reduce the risk of major bleeding. And in the patients with ST segment elevation MI, the pooled effect is to reduce mortality. These results hold up even if you include the Safari trial, which, as all of you know, was a neutral trial looking at 30-day mortality comparing radial versus femoral. What I am going to talk about is specifically what the title is, which is tips and tricks and things that you may run into during radial cases, and some things that we've learned over the years of how to bail yourself out of trouble. So I'm going to talk over the next 25 minutes to 30 minutes or so about access, how to salvage access, how to get up the arm, which is the second challenge, issues with manipulating the catheter, and then, large bore guides. I think there used to be this traditional thought that if you're doing radial access, you can't put in large bore guides. And so that limits the types of PCIs that you can do. And then, everybody's favorite topic is right heart catheterization. I'm joking, of course, but there are some tips and tricks to do right heart catheterization from the arm as well. So I think the one thing to remember is that the fundamentals apply no matter what procedure you're doing, whether it's radial approach, whether it's TAVR, MitraClip. I mean, you want to make sure that you've got very, very good habits, ensuring that the catheters are adequately flushed. You want to take a problem-solving approach. For those of you who are in the interventional lab, you do this all the time. If you have trouble getting a stent down the coronary, you use certain tips and tricks to try and deliver the stent. Really, radial access is no different. If you've got challenges with getting access, if you've got challenges going up the arm, you need to adopt a problem-solving attitude so that you can overcome those challenges. And that I want you to keep that in mind. I think people who are new to radial access will meet a challenge, get frustrated, and then say, well, I knew this radial thing was bogus anyway. But once you sort of figure out what the problem-solving strategies are, you can actually do most of your cases via radial approach. So what if you can't get access? Well, I think there are a couple of things you need to keep in mind. The first is that maybe you stuck too distally in the arm. And we'll talk a little bit about this. So remember that where you're getting radial access is not where you're putting arterial lines in the ICUs. This is a common misconception, particularly for folks who are new to the cath lab to do. They'll say, well, I put in, I get ABGs all the time, and I put A lines in. I'm just going to stick exactly at the wrist. The second is maybe the radial is too small, right? So we're getting a lot of experience now with ulnar access. Almost always, if the radial is diminutive, the ulnar artery is quite big. So, so if you can't get access, and where you will see this is that you will get a flash in the needle, but you won't be able to thread the wire. There's some pre-procedure spasm, right? The rooms are almost always kept too cold. If you're joining a program that is just starting radial access, make sure you train your staff, because how the patient interacts with the staff will result in a level of anxiety that's either very high or very low. When we started our radial program, we made the mistake of not getting the nurses and techs on board. And the patients overhear them talking about how here comes Rao again trying to do radial approach. And that can make the patient anxious. And then sometimes, of course, you can cause a dissection, and you're going to deal with this exactly the same way you deal with dissections in the coronary. So let's talk a little bit about sticking too distal. So this is on the left is a Netter diagram of the wrist. And what you see here is that if you stick very distally in the wrist, right at the wrist, there is something called the flexor retinaculum, which is this fascia that covers the wrist. The problem when you hyperextend the wrist and you stick there is that the artery goes from being a circle to being an oval. So the target actually becomes harder to hit. So you don't want to stick very distally. You actually want to go a little bit more proximally. And where you want to go is proximal to the radial styloid. So in this animation, you can see that the radial styloid is, and you can feel it on your own wrist. You want to go proximal to that. And sometimes you even want to go 2 finger breadths proximal. So you give a little bit of lidocaine, and you don't have to give much. We still give anywhere between 1 and 5 cc's. This is the counterpuncture technique. You get the flash, you pull the cannula back, you see arterial flow, you can put your wire in, and then go ahead and put the sheath in. The reason you want to go proximally is that the artery becomes larger the more proximal you go. And as soon as you put the sheath in, of course, there is a tendency for the artery to spasm, so you want to give vasodilators. Many of these vasodilators, like verapamil, will burn for the patient, so you want to make sure you mix it with blood. Another great vasodilator to use where it doesn't actually burn is nicardipine. It tends to last a little bit longer. The dose is about 250 micrograms. Doesn't burn and lasts a little bit longer. So spasmolytics are very, very important. What if you tried to get access and you failed? If you're one of the fellows, then you just have to be prepared for the attending to make fun of you. We used to, a few years ago, make the fellow do 10 push-ups, but we're not allowed to do that anymore. No, I'm joking, and we didn't really do that, but we used to joke about it. But one thing you can do is just wait. I mean, when you try to access the artery and you hit the artery will want to spasm. So you just want to wait. It seems like, it'll feel like you're waiting forever, honestly. But if you just wait a few minutes, the pulse will return. There are a couple of studies looking at the use of sub-Q vasodilators over the artery. So 100 to 400 micrograms of sub-Q nitro will actually dramatically increase the pulse volume. Again, access slightly more proximal. The artery gets bigger. The spasm usually is not proximal when you fail to access. You can do what's called an anterior wall stick rather than counterpuncture. So use a regular needle and don't go through and through. And then the other thing you can do is you can put pressure on the radial artery distally. So, what this does is if you put pressure on the radial artery just distal to the wrist, you will actually dramatically increase the pulse volume proximally. So I'll apologize for the volume in this, but if you look at, this is a video that Samir Pancholi sent me of him getting access. Now watch what happens here. He gives the lidocaine, and his assistant now, so this is his assistant, pushing on the radial artery distal to where he's going to get access. He's just applying a little bit of pressure there. What you will notice when you do this is that the radial artery will practically jump at your fingers. And if you look at this by ultrasound, you'll actually see this. The VTI dramatically increases when you put a little bit of pressure distally on the radial artery. So this can be very helpful, particularly in cases where the patient is anxious or the room is cold or there's a little bit of spasm. Just have your assistant put pressure on the radial artery distally, and your pulse volume will increase and you can get access. Of course, all of us hopefully are getting proficient with ultrasound. We have made an effort to make sure that almost all access is ultrasound guided now. As you all know, it is a QI metric in the ICUs for venous access. I've always been puzzled why it's not one for arterial access. So those of you who are doing large bore access, even radial approach, ulnar approach, certainly you should be using it because it's deeper in the artery. This is the Rouse trial that Arnold Cito did, showing that there's greater first pass success with using ultrasound guided radial approach, radial access rather. And particularly for difficult access patients, this can be a very, very beneficial technique. So it's really my generation that needs to get more proficient with ultrasound access. I think the fellows in training now have grown up with it during residency. All right, what about getting up the arm? This is a little bit of a sped up video of the street outside of my hotel in India. And I think one of the reasons that radial approach is so popular in India is that Indian people are used to going against traffic. And this is really what you're doing when you're going up the arm, right? So if you have problems, let's say the catheter or the wire gets hung up. As you all know, you shouldn't push harder, right? That's not the right answer. Take a radial angiogram, figure out what's going on. Sometimes it's just tortuosity. It's very, very unusual to have atherosclerosis in the radial artery or some kind of stenosis. Usually there's spasm if you see a narrowing. Sometimes in patients who had prior trauma, we had a patient who had a dog bite when he was 5 years old. He was 70 when he came in for his cath. He had a very tight stenosis in his radial artery. That was from the dog bite that was many years ago. But it's relatively unusual. So take an angiogram, figure out what's going on. Use the techniques you know from your coronary work. So if it's tortuosity, straighten it, right? If it's calcification, figure out a way to get through that calcification with your catheter. Rule out tortuosity or an anatomical variant. This is something that you will see. Francesco Burzata had a terrific paper many years ago looking at the incidence of bilateral variants, and variants included loops or high attachment or high origin radials. It was about 7.5% bilaterally. Rule out a perforation. Remember, the first thing that happens when you perforate the radial artery or perforate a branch of the radial artery is spasm. So rule that out. Generally, going up the arm should not be painful for the patient. And then learn and apply balloon-assisted tracking. I'll talk a little bit about that. So one thing to remember, let's say you're doing a case, you have a little bit of trouble getting up the arm, but you're able to get up. And then you start doing your angiogram, and as you're torquing the catheter, you start the catheter starts getting tighter and tighter, and you're sitting there thinking, geez, this is the problem with radial approach. You have this refractory spasm. Refractory spasm is very, very unusual, and it's almost always because you're in a vessel that you shouldn't be in. So if you're having a lot of spasm, you need to rule out that you're dealing with a radial variant, like a loop and recurrent radial artery, or what we call a high origin or high takeoff radial artery. A high origin or high takeoff radial is a radial artery that originates from the brachial artery, way up in the armpit, not at the elbow. And those will have oftentimes a spasm or narrowing right where they attach to the brachial artery. So here are examples. This is a very, very complex loop on the left-hand side. You can see the radial loop there. And then that tiny little artery is the radial recurrent artery. And what you can see, if you draw a straight line from the radial recurrent artery to the radial artery, it's pretty straight, which is why sometimes a floppy versicor wire or a woolly wire will actually find its way into the radial recurrent artery. You'll go ahead and advance your catheter. You may feel a little bit of resistance, but it'll go. And you sort of breathe a sigh of relief and say, oh, okay, I'm fine. And then as you start doing the case, because the radial recurrent artery is so small, you'll get more and more and more spasm, and you got to rule out that you have a loop. On the right-hand side is what we call a high origin radial. You can see that the bifurcation of the radial and the ulnar is well above the elbow. And again, these oftentimes will have a little bit of narrowing where they hook up with the brachial artery. What can you do if you encounter a loop? Well, you can cross it. Use an angled glide wire, coronary wire, track an angled catheter over it. And then, once you cross it, change out for an 035 wire. I often tell the fellows, you have to cross a loop at least once, just so you can stand up at a meeting and say that you do it all the time. This can be very painful, particularly for younger patients where the loop is fixed to the fascia underneath. So I have stopped crossing loops. I think it takes too much time. It's too painful for patients. It leads to too much radiation. I will oftentimes just bail out to the left radial artery. You can actually bail out to the ipsilateral ulnar. There are 2 registries now showing that simultaneous radial and ulnar access does not result in hand ischemia. And then as a last resort, God gave us femoral arteries for a reason. You can bail to the femoral. Here is an example of crossing a loop. So this was a patient who was a little bit older, in their 60s. So the loop was not fixed to the fascia underneath. This is a woolly wire that we got around the loop. This is a Tiger catheter that we're gently pushing around this loop. You can see we're sort of getting a little bit more purchase around this loop. And then what we do is we pull the entire wire and catheter assembly back and go counterclockwise, and it'll straighten. So counterclockwise, there, it straightens. Now you're off to the races and you can go ahead and do your angiogram. Again, crossing this again, you want to make sure you maintain that 035 wire access. Sometimes it can be challenging to get a guide through that loop. So here's a case where the diagnostic 5 French catheter was able to be advanced and coronary pictures were taken. This patient had an LED D1 bifurcation. They needed PCI. Of course, you want to try and do this with a 6 French guide if you can. And as the operator tried to advance the 6 French guide, they met a lot of resistance just distal to the elbow, and the patient had a lot of pain. So they took a picture, and you can see the staining there. This is a radial perforation. Radial perforations look really, really scary. Now, what you also see is that they were still able to get this 5 French diagnostic catheter across this perforation, but they just couldn't get a guide. Of course, you can't do a PCI through a 5 French guide. So the question is, do they bail to the leg, or what should they do? Well, if you see a radial perforation, again, they look really scary. The first thing is don't panic. These are relatively minor complications as long as you keep your wits about you. Don't pull everything out. This is a common error. And the reason you don't want to pull everything out is that if you can get a catheter across that perforation and complete the procedure, internal tamponade will seal the perforation. Almost always they will seal by the end of the case. And one technique that you can use is called balloon-assisted tracking. With Tejas Patel in India, we helped describe this technique. The idea here is to reduce the transition point between the distal end of the catheter and the wire. So you want to create something that reduces this transition and reduces the razor effect, and an angioplasty balloon is perfect for this. So this is what we did. Through this diagnostic catheter, we put a 035 wire down into the ascending aorta. And you can see that's the 035 is just a run-through wire. Then we took the diagnostic catheter out. Here is the guide catheter. This is a 6 French EBU4, coronary wires across the perforation. Here is a 2015 balloon. Now we use 2020 balloons, so that half the balloon is protruding outside the catheter and half of it is inside the catheter, okay? Then we deploy the balloon at about 4 to 6 atmospheres. So now you have this very nice transition between the distal end of the guide and the wire. And as your assistant will hold the wire, and you can advance the entire catheter balloon assembly, and you will be amazed at how smoothly this catheter will go through a small radial, a loop, an area of spasm due to perforation. And balloon-assisted tracking is not just for radial approach. You can actually use this for a variety of different things that you're having trouble getting through a blood vessel. Ethan Korngold recently posted on Twitter a great case where he used balloon-assisted tracking to deliver a MitraClip device. You can use it to deliver large bore sheaths. You can actually use a 125 balloon through the end of a thrombectomy catheter, manual thrombectomy. I don't know if you're all doing much aspiration anymore. We're certainly not, but sometimes you need it. And if you're having trouble delivering it, put a 125 balloon through the end of that, and it'll deliver very nicely. All right, you can't get the catheters to fit. Okay, this is a common problem. And many of us, in fact, when we did our radial survey, international radial survey, the vast majority of operators around the country, around the world, who are doing a radial approach are using standard Judkins catheters. They're not using dedicated radial shapes because we sort of know how those catheters behave. So what can you do? Well, engage, if you're using, the challenge is all with the left side. It's not the right. The right is relatively easy to get. It's the left main because, again, the Judkins catheter is designed to come from the femoral. So what you can do, and many of you who are starting in the cath lab may have noticed that sometimes the catheter will curl up in the ascending aorta, which can be frustrating. The key is to use the 035 wire, have it be your friend. Engage the left main with the JL catheter with the 035 wire in. Once you're pretty sure you're in the left main, you can pull the wire out and check pressure because you want to make sure you're not in a plaque. Use the left radial approach, even if no lima. Sometimes the vein grafts are just easier to get from the left radial access rather than from the right. And most of the time, you need a little bit longer catheters for vein grafts, a multi-purpose, a left coronary bypass, or an Amplatz. What about guide catheters? The 035 wire is your friend. Leave the wire in and manipulate the guide with the wire in. In fact, you can purge your guide and leave the wire in, so you can even puff with the 035 wire in. Use this. Sometimes, if the guide catheter keeps curling up on you, or you've got a big Z curve coming from the right subclavian into the ascending aorta, what we will do is we will force the guide catheter to actually intentionally curl up. And then we will take the straight end of the 035 wire to unfold the guide into the left main. So here's a diagnostic case. This is a JL catheter. You know, if you have a straight shot into the ascending aorta, you almost always end up in the non-coronary cusp. So what we do is we pull the catheter back and go clockwise. And you'll see we pull the wire back in, we pull the catheter back and go clockwise, but it ends up underneath the left main. In that case, don't pull it back, just push the catheter forward so that it sticks up into the left main. Then you can pull the catheter back gently and go slightly clockwise and it'll become coaxial. Sometimes the catheter will just do it on its own. So here's a case where the 035 wire is still in, but the JL curled up in the ascending aorta. We just turned it towards the left main and gently pulled back, and the tip of the catheter engages the left main, and you can do your angiogram. Here's a case where this is an EBU4 guide. The 035 wire is still in the guide. So we pull the guide back and go clockwise. It ends up in the left coronary cusp, but way underneath the left main, right? So push the guide down gently, go counterclockwise with it. Here we're going counterclockwise. There, now it's stuck in the left main. You can pull the catheter back and become coaxial. Remember, for those of you who are interventional fellows, when you pull that EBU or XB or whatever curve you're using, and you're coming from radial access, when you pull it back, it will behave a little bit like an Amplatz and the tip will tend to dive. So just be a little bit careful where you're getting the support from. The EBU oftentimes is lower in the aorta rather than just the contralateral wall. All right, what about large bore guides? Again, the idea used to be that you can't do complex PCI from the radial approach because you can't put large bore guides in. What we know is that sheath sizes generally result in arteriotomies that are bigger than the actual catheter itself. So there's interest in using a sheathless approach. Now, I'm old enough that when I trained, we did a lot of our transfemoral diagnostic cases without a sheath. We would just put a 6 or 5 French diagnostic catheter in through the femoral artery and just do it without a sheath. If the patient needed PCI, we would put a sheath in. Because again, you have a smaller hole than you would with a sheath. Well, now there are several ways that you can do this. So several companies now offer these thin-walled sheaths. Maybe you all are using these sort of so-called slender, where it's a relatively clever idea. They take a 5 or a 5.5 French sheath and thin the walls so that you can put larger guides in. You know, a 6-7 slender or sheath is great. You'll make a 6.5 French arteriotomy in the artery, but you can actually put a 7 French guide through it. There has not been convincing evidence that this reduces radial artery occlusion. We were involved in the RAP and BEAT trial that compared this against a standard sheath, and we were not able to show that it reduces radial artery occlusion, but certainly it does facilitate using large bore guides for PCI. There are dedicated sheathless systems, the Asahi OCath. This is a 7.5 French guide that comes with a long stylet and a very hydrophilic guide catheter. It's very, very smooth. The entire catheter is hydrophilic coated, so it glides up the arm very, very nicely. You have to be a little bit careful with these. The tip tends to be a little bit stiff. In the early experience, there's a learning curve. There's some left main dissections. So be careful when you use these, but they tend to be very roomy and can be very helpful for complex PCI. And then, of course, there are homemade techniques. This is, I borrowed this slide from Rajiv Gulati's paper, where they took a 7 French guide that's a cordis guide. They put a 5 French 125 diagnostic multi-purpose through it to create this transition that will allow you to get into the radial artery. The big advantage of some of the dedicated systems is that they are hydrophilic. So in order to facilitate this going up the radial artery, you can give about 10 cc's of Rotaglide through the artery, and this entire assembly can be advanced very, very easily up the arm into the ascending aorta for a complex case. All right, what about right heart caths? Well, we do a lot of these. You know, we have a very robust transplant program. This is oftentimes a reaction of the interventional fellows when they get stuck in a right heart cath case. But these can be kind of fun if you do them from the arm, because again, it's very easy on the patients. The access is basically like putting in an IV. We had a case where a patient needed a right heart cath as an outpatient. They did not want sedation, and honestly, they don't need sedation for a right heart cath. So we did the right heart cath, pulled the catheter at the end. The patient walked out of the hospital and went home because they never got sedation. And honestly, there's really not much recovery from this. Remember that there's a lot of variability in the veins compared with the arteries. I mean, the arteries are relatively straightforward, except for the small proportion of patients who have anomalies. But the venous system can be very, very complicated. And the big issue is, you know, which vein going up the arm do you access? Most of the time, you'll get access into the cephalic vein because that's where the antecubital vein leads to, which is fine. The problem, of course, is where the cephalic vein joins the axillary vein, there's a T-junction. And sometimes you run into issues trying to get the catheter through that. that's relatively easy to traverse if you just put a coronary wire in to straighten it. The preferred access would be the basilic vein, which is more medial in the arm. The basilic vein is very, very large. You can actually do endomyocardial biopsies through the basilic vein, but you will need ultrasound oftentimes to get access in the basilic vein. One thing that I'll mention as a side note is that, we have our nurses put in the IVs sterilely. Our hospital went to hospital-wide safety IVs, these butterflies, where there's no direct route between the catheter and the actual vessel. What we discovered is that you can actually take a micropuncture needle and go right through the back of the rubber stopper of these butterflies, and you'll get access to the vein. So that's what we use. We just go ahead and puncture the back of this IV, and then you can go ahead and put your wire in and get access to the vein. Again, the IVs are put in sterilely, so it's not an issue. If you can't get access, there are a couple of things you can try. I mean, the most straightforward thing, of course, is to just use ultrasound. There is something called a vein finder. I don't know if any of you are familiar with this. It's kind of a cool device. It shines some kind of a light onto the patient's arm, and you can see all the veins. It makes them look like a zombie, but you can see the veins pretty easily. Ultrasound is the easiest thing to do. And again, if you're facile with ultrasound, this can be very helpful. One thing that we described along with Samir Pancholi is this technique called the Leva phase technique, which again, I just mentioned it for historical purposes. It's really not all that useful in the era of ultrasound, but it's kind of a cool technique that Sam discovered. This is very helpful for patients who needed a left and right heart cath. So you're getting radial access anyway. So in this case, here's what you do. You go ahead and put your arterial sheath in, and then you inject contrast, and then you just wait a few seconds. And what you'll see is the veins filling, and you can go ahead and access that vein under fluoro because you'll have contrast in the vein. So here's an example. Here's the brachial artery. If you keep your eye sort of just to the left of the center of this picture, you will see this vessel filling. And you can see that's the cephalic vein going into the adenocubital vein right there. So that, we have a tourniquet on the patient. So there's that standing column of contrast. So just under fluoro, we go ahead and access that, put our wire in, put our sheath in, and then we're off to the races with our right heart cath. Again, it's kind of a cool technique, but probably more of historical interest. This is a vein that you could easily find with ultrasound. Okay, so there are a couple of things that sometimes are challenging with right heart cath, usually in patients who need a right heart cath because they've got terrible TR, they've got a big right atrium, they've got a right heart failure, and it can be challenging to get the catheter from the right atrium to the right ventricle. Oftentimes the right atrium is very large, and the reflex, of course, is to say, well, just give me a wire. And you'll open a coronary wire and put that through and go ahead and access the pulmonary artery. But one thing to try is something called the hydraulic guide wire technique. And next time you're doing a right heart cath with a 5 French catheter, do this on the table. Go ahead and attach a syringe to the end of it and inject saline through it and watch what happens to the tip. The tip of the catheter will straighten a little bit and it'll stiffen. So that'll allow you to get across. So here's a case where the right atrium is very large. So you're advancing the right heart catheter, it keeps curling up, and you say, geez, maybe I need a wire. Well, before you ask for that wire, have your assistant inject saline while you advance it, okay? If you inject saline while you advance this catheter, the tip will straighten and it'll pop across the tricuspid valve. Watch. So injecting, there it goes. It just pops right across because that tip will straighten and it'll stiffen just enough so you can get into the right ventricle, and then you can go ahead and do the rest of your pressures. If this doesn't work, of course, go ahead and get a wire, but most of the time this will work, so you can save your cath lab some money and Azim won't get in trouble. And then, what you can do if the patient is going back to the floor, rather than try to get manual compression, which in most programs means that the fellow is holding pressure, you can replace the 5 French sheath under sterile conditions with a 14 gauge IV. The outer diameters are about the same. You'll need an angiocath to do this. You put the 5 French dilator through that angiocath, go ahead and put the wire through the sheath, remove the sheath, and then over that wire, you can put this assembly. The reason you need the dilator is that you do need a transition point to allow the IV to go ahead and go through the skin. This is a very satisfying technique that will send the patient back to the floor with an IV in, placed under sterile conditions, and you won't have to hold manual compression. So I'll summarize here, and we've got some time for questions. Honestly, even if you end up not being a radial first operator, you really should be proficient with radial approach. And it takes a little bit of time, but not much. The learning curve is not that steep. And 90% of the cases, and this is true for almost every procedure, are straightforward. But about 10% of them, you have to have a problem-solving attitude, and radial access is no different. some sort of pearls to take home are distal radial pressure and sub-Q nitro to facilitate radial access. The 035 wire is your friend, particularly for guide catheters. Remember, balloon-assisted tracking, this will bail you out in many places. Large bore is possible with radial access. And then the hydraulic guide wire technique for right heart caths. So again, I want to thank Azim for inviting me, and I want to thank everybody for joining this Cath Lab conference. I'm happy to take any questions if people have any.
Excellent. Thanks. Sunil, that was awesome. I mean, you packed in like tons of tips and tricks that most of us have, like, it's taken us years to develop all of those tips and tricks. So thank you for spelling it out so well for all the fellows. I'm going to let Theo also, Theo, if you can join and address some of the questions. Please use the chat function for your questions. One of the comments I wanted to make, Neil, is I've been using a lot of Brachial as well for my right heart caths.
Yeah.
And one of the things I've learned recently that's I think useful, and because I've gotten myself into trouble, is to check whether the patient has a pacemaker or not.
Yeah.
And not to go the side of the pacemaker.
Right. Yeah. Absolutely. And I'll just say something in a joking manner, but this is a good way to know whether the fellow has evaluated the patient appropriately, is when you get access and you're going up with your catheter and you step on fluoro and you realize there's a defibrillator or pacemaker on the side that you're going on. But you're right. I mean, and the reason to do that obviously is that there's a tremendous amount of scarring that can occur and then collateralization that just will limit whether you can get the catheter through. So that's absolutely right. Yeah.
Theo, it's all yours. Theo is one of our new interventional fellows who's come to join us, and he'll do some of the questions with you, Sunil.
Thank you, Dr. Rao, for this excellent presentation. Actually, as a new fellow, I found most of the tricks and the tips, very useful. I was really amazed about the tips you told us about the right heart cath. That I never heard that before. So a few questions, like my personal questions. Do you routinely, we didn't talk about that, but what's your approach about the left radial access? Any differences compared to the right radial in the technique?
Yeah, so good question. I think we do about 25% left radial. We have a pretty large post-bypass population. The other two groups that I tend to use left radial in is patients who are 70 years of age or older, or patients who are 5'5" or shorter. And the reason is that there are two studies, one out of Canada, one out of the United States, that show that in those two age groups, there is more right subclavian tortuosity. Interestingly, there are different studies, different data sets, but they both came to the same height cutoff. The Canadian study used metric and the US study used English, but it's 5'5". So, if I'm on STEMI call and we have a patient coming in, usually the age, hopefully, and if they're over the age of 70, I'll just say, let's set up for a left radial. The challenge with left radial is all the setup. It's not anything else. I mean, the catheter manipulation is about the same. I think the maybe a little bit easier, quite frankly. That's what the Talent trial showed, but it's really the setup. And I think the setup can be facilitated by making sure that the patient's left arm is brought across their body. So what we do is we get access on the left side, actually have the patient, we put the 035 wire past the elbow through the sheath, and then we have the patient lift up their arm, put it across their body, and then we try to support their arm. And it tends to work very well. Where you run into a problem, and this is increasingly a problem, is in patients who have a very large pannus. It can be very challenging. And in those cases, many of you may be familiar with distal radial access. I didn't talk about it much, but the so-called snuff box approach can be helpful, where the patient can just put their hand pronated on their abdomen and you can go ahead and do your case.
Yeah. I must admit, so in all honesty and transparency, I'm a left radial person, almost completely. I do right when I can't do left. And I remember, when we started, we moved to left radial in Milano. So there were a couple of us only doing right radial, and we couldn't convince Antonio Colombo to do radial, right? He was still, no, I need my femoral. I can do everything femoral.
Yeah.
And then when we had some challenges cannulating or difficult because of tortuosity, or we're taking long with the case, he'd walk in and say, you see, I told you, all you're doing is wasting time. And so we switched to left radial because of that paper, showing that less tortuosity, even our own experience. And then our radial practice grew, the procedures were quicker, the fellows were cannulating better, as the attendings weren't having to go in all the time to bail out the fellows. And even Antonio became convinced, right? Wow. And so now, and I always use the example when people tell me, I've been doing femoral for years and I'm perfect, is I give the example of Antonio. Antonio at age 62, 63, converted from being femoral first to radial first. Yeah. Right. So, I mean, he set a pretty high bar for all of us.
Yeah, absolutely. And, I think what at least people of that generation have told me in our practice is that their learning curve was actually quite a bit shorter because they were used to doing sews. So their learning curve is from the wrist to the elbow. Whereas for the rest of us, it was much, much different.
Yeah, absolutely. Sorry, Theo, go ahead.
Also here, Dr. Latib, he uses the long sheath. When we do the left radial approach, he uses a long sheath, and it looks like that from my minimal exposure with him that we haven't encountered a spasm. We avoid these kind of complications. What's your thoughts about the long sheath to go?
Yeah, I think it's a great idea. It's particularly for left radial because you can, it sort of saves your back a bit. There was a randomized trial that Sudhir Rathore did, many years ago now, it must have been 5-6 years ago, comparing sheath length and radial artery spasm, and found really no difference. Sheath length didn't make a difference. Yeah. So, like a lot of things, people end up basing a lot of their arguments on faith until you get some evidence. And so, there were people who said, oh, no, you never use a long sheath, and people, always use a long. And the reality is it doesn't matter. I mean, if it makes your procedure easier, particularly for left radial, where you can have a little bit of the sheath hanging out, then that's great. There's actually a device called a stand tall, which you can attach to the back of a standard length sheath, and it will lengthen your sheath for you. It's designed specifically for left radial. So I think it's a great technique to use a long sheath, particularly for left radials.
Okay, so a few questions from the audience. First question is what is the best way to apply the subcutaneous nitroglycerin?
Yeah.
Yeah,
it's exactly like giving the lidocaine. You just want to create a wheel into the dermis, and that will actually result in some vasodilation. Some centers like to put a little bit of Nitro Paste on the wrist as they're prepping the patient. I think that works fine too. You have to be a little bit careful with the amount of Nitro Paste you're putting on, because patients can get hypotensive or they get a headache or something. With the sub-Q nitro, you can titrate the dose a little bit better.
And you prefer subcutaneous to sublingual nitro, or doesn't matter?
I don't think it really matters. I mean, honestly, I think one of the lost arts in the cath lab is good angiography, and we really should be giving intracoronary nitro before our pictures. In the old days, every patient would get a sublingual nitro before we got pictures. But I think if you're dealing just with access, sublingual or topical probably doesn't matter. Maybe the topical or sub-Q may be helpful if the patient comes into the lab with soft pressures.
I see. Another question is that there's any safety concerns with a radial ulnar approach?
Yeah, I'm assuming the question is related to simultaneous access. I think it's certainly not something that we would do cavalierly. In cases where it was done, at least the data that have been published or observational out of Italy suggests that there's no risk of hand ischemia. The hand itself is remarkably collateralized. There is the interosseous artery that will oftentimes take over. And this is one of the reasons why the Allen's test or the Barbo test is not predictive of radial artery occlusion. It's because it doesn't account for the tremendous collateralization of the hand. Now, having said that, would I routinely do radial and ulnar access simultaneously? Probably not. I mean, I think, if you have trouble with right radial access, go to the left. You have trouble with left radial access, go to the right. If you've not put a sheath in either artery, then I think many of us feel comfortable going ahead and accessing the ulnar artery at the same time.
Are you guys routinely doing Allen's tests before your procedure?
We're not. We use the reverse Barbo to check for radial artery occlusion before the patient goes home, but we're not using it to triage access at all.
Okay, good.
One question about the antithrombotic a strategy for patients with a radial access. I know there are some publications where the suggested high dose of heparin might prevent the radial artery occlusion. So I think that in one protocol they used even 10,000 units of heparin. What do you recommend, or what do you use routinely?
Yeah, that's a great question. I think what's becoming clear is that similar to what happens in the coronary arteries, higher ACTs are associated with lower radial artery occlusion in general. So there's the Greek trial, the Aura of Artemis, where they randomized patients to 2 different doses of heparin. Higher dose was better than lower dose. I think the challenge with those studies and the challenge with applying that in clinical practice is there is another variable that goes into it, a couple of other variables, right? So one is, what is the size of the radial artery and how much stretching are you getting with putting the sheath in? The second issue is, how good are you at applying non-occlusive hemostasis? And in fact, it might be non-occlusive hemostasis that's the most important variable. And in many of these studies that have looked at different dosing of heparin, there wasn't routine non-occlusive hemostasis. We tend to use a fixed dose of 5,000. Where does that come from? Well, it comes from Ivo Burnat's randomized trial, where he looked at 2,000 versus 5,000. And he also looked at what's so-called ulnar compression just before discharge to recanalize the radial artery. So that's what we use. Of course, most angiograms hopefully don't take very long. You're talking about 2-3 minutes of fluoro time. And at that point, you can decide whether you're going to do a PCI, at which time we apply guideline recommended doses of antithrombin therapy for ACT. If you're not going to do a PCI, you can just go ahead and do non-occlusive hemostasis. We did a QI project in our lab about 5 years ago where we measured radial artery occlusion in 200 consecutive patients. And our rate was around 0.8%. And that's because our recovery area nursing staff is very meticulous about non-occlusive hemostasis. And so, I think that's, again, probably the most important variable for radial artery occlusion.
And now, also there are questions about, starting from the distal radial, brachial arteries, like what's your experience with all these different access points?
So I think, distal radial is a great technique. I will admit that in my hands, I've not been as successful as some of the folks that have posted on social media. I think you do have to use ultrasound to get access. It's a little bit more challenging. I think that there's probably a learning curve associated with that. Interestingly, brachial access in a randomized trial comparing brachial, radial, and femoral was associated with the highest risk of complications. So I think most of us are probably reserving brachial access for really no other access. It is, if you compromise a brachial artery, you can really compromise the entire forearm. It's a big artery, so it's easier to get access, but hemostasis can be challenging. So we tend to avoid the brachial artery when we can. I think distal radial is great. It takes a little while to get used to and get good at it.
One other question is that what size of sheath do you use for biopsies, from the arm?
So there's a biopsy sheath that we use. Again, if we're doing it from the arm, which is still pretty unusual for us, you have to use ultrasound. You have to get into the basilic artery. It's a long 7 French sheath that will fit 2 different manufacturers of biotomes. Like I said, we have a pretty busy transplant program, so we're doing a lot of biopsies. Most of them, I'll be honest, we're still doing them from the leg using ultrasound guidance, and then the balance are being done in the clinic just through the neck.
There's one comment here, and actually it was one of my questions, but the opposite. They say, doesn't left radial approach increase the radiation exposure? And I think from the talent study, actually quite the opposite. The left radial compared to right radial had less radiation.
Right.
Right.
That's correct. Yeah. I mean, in that randomized trial, there was less radiation with left radial, probably because the procedures were just faster. As Azim indicated, it's a little bit easier to use, so your diagnostic angiography takes less time. There are some observational studies suggesting the opposite. Now, I think those are confounded by the fact that the patients who were more complex were selected for left radial. So if you're comparing someone who doesn't have bypass grafts with someone who does, obviously the patient who has bypass grafts is going to take longer procedure times. So you have to be a little bit careful with that. But you're right. I think in the randomized data, there's less radiation exposure with left radial access than there is with right.
Let's see. Can you please describe, maybe briefly the steps if someone faces radial artery avulsion, like maybe some perforation? I know you mentioned that, but in the discussion.
Yeah. So we should distinguish between radial artery avulsion and radial artery perforation. So perforation is basically what it sounds like. And almost always what the perforation is a small branch of the radial artery due to the access wire perforation. That's what it is. Like, you're advancing the wire. Most of us don't do that under fluoroscopy. You meet a little bit of resistance, so you pull the wire back and you spin it and it goes fine. That little bit of resistance, maybe the wire has actually gotten into a small branch. Maybe you pushed a little bit hard and that branch perforates and you get some bleeding into that into the fascia and you get a forearm hematoma. There are occasionally radial artery perforations where you've actually ripped the radial artery. Those are thankfully rare. The key in either one of those cases is to maintain access to the radial artery, get a catheter across it so that it can seal internally. Radial artery avulsion, I will admit, knock on wood, I have never seen that. Now, it's been described, and almost all of us have that slide in our slide set. Where the patient is laying on the table and this sort of looks like a tapeworm coming out of their wrist. It's the radial artery. That really, in my opinion, should be a never event. That means that people were not paying attention to the fact that they were getting very severe spasm, and they were either in a radial anomaly or they were trying to put a large guide through a small radial. Hopefully, that's a never event now that we have ultrasound that we can evaluate the sizes of the radial and the ulnar. A radial artery avulsion, you probably ought to call the surgeons. I mean, the patient should be fine because there's so much collateralization to the hand. They generally won't get hand ischemia. But the key is, for those of you who are fellows in training, is that if you're getting a lot of spasm, figure out where you are and make sure you're not in too small of an artery. If you are, bail and go to a larger artery. And the second thing is that if the nursing staff in the recovery area call you and say, I think this patient has a hematoma, you have to go see the patient. Because the way patients get compartment syndrome is when the hematomas are ignored and they get too large, and all of a sudden, you're dealing with a patient who's got a huge forearm, they're having a lot of pain, and you got to take them to get decompressed. So if someone says, I think this guy a guy or gal has a forearm hematoma, go see the patient, evaluate it, and if you can get on those early just by wrapping the arm, it will really not cause a problem.
So Sunil, let's talk about both of those. When you do see a forearm hematoma, do you just wrap it, or do you put a blood pressure cuff on to try and compress it?
I usually just wrap it with an ACE bandage. Usually, if you catch them early enough, you can just sort of externally compress it, and patients do fine.
Yeah, and then I'll maybe make a comment about the avulsions. I haven't seen one either, but I've seen them described, and I've spoken to colleagues who've had one. And most times they occur when you have a really bad refractory spasm and you pull too hard on getting your sheath out, particularly long sheaths. So if you're going to use long sheaths, you have to use long sheaths that are made for the radial. So, these Terumo sheaths, and the reason being is that if there's spasm and you start pulling them out softly, they actually do compress. The worst thing I've seen happen is people trying to do peripherals from the radial, and they use like a Terumo normal peripheral sheath, so a destination, okay, a long destination, and you get spasm. Now, for something like that, that's bad because those sheaths are reinforced, and you will not get them out if they go into spasm. So maybe we should talk a little bit about, if you have a really bad spasm, what you could do and how you would get the sheath out.
Yeah, absolutely. So I was just thinking that, I think obviously pharmacotherapy is the cornerstone. So you can give vasodilators. Obviously sometimes you give so many vasodilators, the patient starts getting hypotensive. A great technique is, vasodilation just from compression of the arm. So what you can do is, blow a blood pressure cuff up 10 to 20 millimeters of mercury above the systolic pressure, leave it on for a few minutes. Now, the patient will be uncomfortable, so you have to warn them about it. And then after a few minutes, release the blood pressure cuff. And oftentimes the catheter, the entrapped catheter, the sheath will just slide out. That's because what you've essentially done is you've caused ischemia reperfusion of the arm. And when you get ischemia reperfusion, you get tremendous vasodilation. This is a technique that's been described and published by Rajiv Gulati and Samir Pancholi. It's really a terrific technique. So, it's vasodilation just from after release of compression. And that will work, most of the time. That will lead to enough vasodilation you can remove the entrapped equipment. Occasionally, and again, thank God I've never had to do this, but I have heard of people having to do this. You have to call anesthesia. They have to do some kind of a nerve block, but hopefully that will be a rare event.
Yeah, I've even heard of cases where anesthesia has had to put the patient, has had to do a general anesthesia. to get a catheter out, a long sheath out. Those, like I said again, I've never seen that happen in my practice, but it's apparently described. Theo, please carry on. There's still some interesting questions here on the chat.
Yeah. So one question is that if you encounter difficulty with the engaging the coronaries due to, let's say, extreme subclavian tortuosity, do you prefer to use the ipsilateral arm or maybe to go like a femoral approach?
Yeah, good question. We generally tend to go to the other arm. Maybe it's just because I'm getting older. I tried not to be a hero in these cases. You know, if you're dealing with a lot of right subclavian tortuosity or what's called an arterial lusoria, where the right innominate will plug in distal to the left subclavian in the aorta. Those are very, very challenging. My strategy is just to bail to the left arm. And as Azim said, if you're going routine left, you're not going to encounter a lusoria because it only occurs on the right side. So yeah, I try not to be a hero. I think we all have a lot of stuff to do during the day. The patient doesn't want to be on the table for a long time. If you're dealing with a lot of challenges with tortuosity, I would recommend bailing out to the other arm.
Yeah, I agree. I think you also increase more manipulation you increase the risk of complications and stroke.
Yeah.
You know, the one thing I do, if it's not too severe, I'll quickly change from a diagnostic to a guide.
Yeah.
To do my diagnostic part, right? I'll take out the diagnostic. I'll put a guide in with, like you mentioned, with my 035 wire in, and I'll cannulate with the 035 wire in just to take my pictures, and then maybe come back to do the PCI from the other side or from the femoral.
Yeah, that's great, and that is a great example of applying problem solving that you often use in the coronaries to this, right? So if you're using a routine 5 French diagnostic and you're having trouble manipulating, put a 6 French diagnostic in, right? All you're doing is making the equipment a little bit stiffer to make it more manipulable. You do the same thing in the coronaries. You have trouble delivering a stent, you're going to put a stiffer wire down, right? It's that same sort of mentality that you want to use when you're troubleshooting from the arm.
Yeah, absolutely. One of the questions that comes up all the time is universal catheters for left and right. I personally use standard catheters. What about you?
Yeah, I tend to use standard catheters as well. One of my colleagues loves the universal diagnostic catheter, that tiger shape from Terumo. Mm-hmm. We started using those. I found that at least in my hands, I was getting the right coronary on the first try about 75% of the time. But 25% of the time I had to manipulate it a little bit more. So I thought, well, I'll just go to the regular Judds and it works fine. Similarly, we tend to use standard guide catheters for PCI, EBUs or XBs for the left, JRs or Amplatzes for the right. There are obviously universal guides and catheters. I think one of the challenges of the universal guides is that, a fundamental law of angioplasty is that things that are easy to put in are easy to take out. And if you're doing a very, very tough case, you want a lot of guide support. So using a universal guide, which is very easy to seat in the coronary, you probably aren't going to get a lot of support out because it's going to want to pop out all the time. So, you may, as an interventional fellow, the first 3 months, you're really struggling to get those EBU guides in from the arm and you're worried about dissecting the left main, you're going slowly. If it's hard to get in, you're going to get tons of support out of that guide, So yeah, you got to be careful. But once you get that guide in, it's not moving. The one place where universal guides may be helpful is in the STEMI population, where you can go ahead and shoot both arteries and go ahead and get started with your PCI. Most of the time, you don't need a lot of support for a STEMI PCI. Occasionally you do, and you don't want to get burned, but we're not using a lot of universal guides in our practice.
Okay, well, great. There's also, one of the fellows asked, and I never thought about this, and maybe it makes sense. You showed the data, and I saw that paper in CCI about using subcutaneous nitrates if you have spasm. So why don't we, when we give lidocaine, just mix some nitro with it and do that routinely?
Yeah, in fact, a lot of people will do that.
Okay.
They will do lidocaine with nitro, or they'll do heparin with nitro and give that through the sheath. But I think it's a great idea. It's not part of our normal workflow. So, oftentimes the way the cath lab rooms are set up is that you've got your lidocaine syringe and your nitro syringe. So rather than, die on that hill, we just figured, we'll just give this up through nitro instead.
Theo, any other questions?
Yeah, can I ask you something also? What's your approach or the difficulties when you have to deal with a patient on dialysis? I know there are some controversies about because of every fistula, you don't want to sacrifice the other arm. You have to be extremely careful. What's your approach with these patients?
Yeah, so good question. We don't traverse active fistulas. There was a case series presented at TCT 3 years ago from an Italian group where they actually went ahead and went right through the fistulas. We tend not to do that. I think that makes the nephrologist very upset. We are routinely using radial access in the dialysis population or in CKD populations. In partnership with our nephrologists, these patients are at very, very high risk for bleeding complications, so they're going to get the most benefit. Now, obviously, there is an issue with the formation of AV fistulas, and there are national preserve the graft initiatives. A couple of comments there. One is that I think if you're very careful about making sure that you don't get radial artery occlusion, it's less of an issue. The second thing is that oftentimes the occlusion that occurs is very distally in the radial artery, right where you get access and the entry point of the sheath. So the AV fistula can be placed more proximally. The third is that when AV fistulas fail, it's almost always on the venous side, not on the arterial side. So I think those three things have really, bolstered our practice to routinely use radial access when we can in the CKD population.
Yeah, I would agree. I mean, I also, initially years ago, people would say, if you want to spare contrast and you're doing a patient, we want to do a minimal contrast procedure, don't use radial. I completely disagree. I mean, I use radial for all my zero contrast PCIs and, in patients with creatinines of 2 and 5 and 3 routinely, and also for all my graft patients. I use left, it doesn't matter how many grafts they have, unless they have bilateral memories.
Right.
If they have bilateral memories, then I'll go femoral. I'll just make my life easier.
Yeah, absolutely. And remember, in the Matrix trial, which is a randomized trial of radial versus femoral, although it was not, this wasn't the primary endpoint, it was pre-specified, there was less acute kidney injury with radial access than there was with femoral access, even after accounting for differences in contrast. So it may be something about traipsing up and down the descending aorta that also increases the risk for AKI and femoral access.
Theo?
One more question. What are the optimal dedicated radial guiding catheters for left and right coronary artery?
Yeah, so that's a great question. I'm probably not qualified to answer that because I just don't have a lot of experience with universal guides. I think the one that there are two that I've had some experience with. There's the Kimney guide, which was developed by Ferdinand Kimney, which is for right and left. And then there's the Ikari guides. Now, interestingly, the Ikari guides are universal, but they come in a right and left. So it's a little bit confusing. So I'm just, probably not the right person to ask. Azim, I don't know if you have any experience with some of these guides.
No, I must admit, I use standard guides. I use whatever I would use from the femoral, especially from the radial, exactly the same size as I would use from the femoral. I like what you say. One of the points I want to stress to maybe the fellows, and I almost do it routinely, when I'm trying to put in an EBU or XB guide catheter in, I actually like it when it closes on me, okay, and in the aorta, because I immediately then take out the wire, the 035 wire, and I go with the back of the 035 wire. You just got to make sure you don't come out, and I just flip it open and it goes in really nice. And I almost think it should be almost the standard approach for how you put a EBU or XB from the radial.
Yeah, it's certainly a safer way to do it, I think, because you're coming in from above the left main rather than coming in from below, where you can really sort of stick up into that left main.
Yeah, absolutely. I know Shun, one of our other fellows, asked about hydrophilic guiding catheters. Apparently Boston, I don't know the guiding catheter. I don't know if you have any experience, Boston convey guiding catheter when you have difficulty with spasm.
No, I don't. I mean, the Asahi sheathless guides are very, very hydrophilic. When we do, we've done a fair number of cases where we wanted to use large bore, keeping in mind most of the PCIs you can get done with 6 French, but occasionally maybe you want a large bore guide. The Asahis are very, very hydrophilic. Again, the downside of the upside of hydrophilicity is that it's easy to deliver. The patient tolerates it fine. The downside is that, again, they tend to be pretty slippery, so they may not stay in the left main as much as you want. So it's always a little bit of a trade-off.
Yeah, I mean, that was one of the things I didn't like about this Sai when you first learn. I mean, the one you have to be careful of the dilator, right? Because the dilator extends out quite a bit, and so you have to be sure when you get in the arch, you're actually pulling that dilator back. But the other is that as you push it in, you got to make sure that you don't wet the whole thing, and because otherwise it's just slipping in and out if you've activated the hydrophilic coating. So yeah, I stopped using it, because of the slenders. Because when slender became available, I can now stick a 7 a 7 guide easily in most patients based on ultrasound for complex PCI. I've not tried to do 8. You know, there's a group of Italians who are pushing, sort of doing BAVs via the radial. Because in Europe, we don't have any of these balloons here, but in Europe, there's a balloon called Crystal, where you can get an 18 mm balloon that goes in an 8 French sheath.
Wow.
Yeah.
Interesting.
So in Europe, you could actually, if you can get an 8 French sheath in the radial, you could do a BAV from the radial.
Wow.
And paste over the Y and the ventricle. So there's a group of Italians who have a lot of experience with this and have, you know, published a little bit on it, which is interesting. But in the US, we can't do that because we don't have balloons. We don't have these balloons.
Right, right. Well, I'm waiting for you to invent the transradial TAVR, Azim. And I know we've arrived.
Absolutely. Theo, any last burning question before?
The last question is, what limitations have you found with biopsies with a basilic vein access?
Yeah, that's a good question. I think the biggest barrier is really just getting access and advancing up the arm. You know, it's the vein, so patients generally shouldn't feel any pain when you're advancing the catheter, but getting this large sheath through the skin sometimes can be very uncomfortable for patients, and negotiating that curve into the SVC can be a little bit challenging. Once you get it through, it's just like doing a biopsy from the neck. It sort of goes right into the right ventricle and you can get the biopsy. But those are the two challenges, is getting the sheath through the skin and getting around that curve.
Okay, that question I think is really relevant. Any considerations in tall people with like long arms? Because you frequently see these patients in the cath lab, and it's better to have a strategy right before you start the procedure. Sometimes you don't realize when you see them laying in the table how tall they are. But
right. It can be challenging. I mean, you know, to reach the coronaries from radial access in a tall patient. Oftentimes, you know, these cases tend to be challenging no matter what, because they sometimes will have femoral tortuosity as well that limits things. So, you know, I think I would approach it exactly the same way. You know, you have a certain routine way of approaching a case, and then you've got to problem solve from there. And if that means that you've got to bail out to another access site, I mean, I think that's okay. You shouldn't consider that a failure. At the end of the day, the goal is to make sure you get the information and get the best pictures that you can so you can help the patient make a decision.
There were a couple of questions about AL catheters from Radial. You know, one of the people who taught me was using it routinely, an AL1 to do left and right. I really don't like that. I think, you know, AL catheters should only be used in very specific circumstances. I have to admit, I do use more ALs from the radial compared to femoral, but that's usually to engage venous grafts, SVGs. Yeah. What about yourself?
I'm the same way. I mean, when I was a fellow, one of our attendings liked to use an AL2 to shoot the right and the left from radial access. He was one of the few people who was doing radial approach in our practice at that point. But I agree with you. Again, I think it comes down to whether you're a believer in universal catheters or not. I think, as you said, the more you manipulate a catheter, the more spasm you get. And universal catheters, you tend to manipulate a little bit more. So I tend not to use them. I will use them for PCIs, for Shepherd's Crook rights and stuff like that. But otherwise, you know, I agree with you. I think just standard catheters are fine.
Yeah. Sunil, the questions will keep coming and we'll be here all day, but I don't want to keep you away from the lab. You've already given us an hour of your time. Really, that was fantastic. So many tips and tricks. If you don't mind, we put this on YouTube for people on our channel, for people to watch and re-go over all the tips and tricks that you've showed us. Once again, thanks for your friendship and thanks for joining us today. It's meant a lot.
Thank you very much, Azim. Thanks so much. It was a real pleasure, and I appreciate all the fellows dialing in and everyone else as well. Thank you. Have a great day.
You too. Take care now. Bye-bye. Thanks, Theo, for your help.
Yeah, of course. Thank you.